So I think the previous presentation was very, very helpful for me because I'm looking at this from a different perspective. I like the word of active observation when we see patients with CLL, where actually the activity could be in keeping the patient under active care by the doctor and putting his worries at bay. On the other hand, when you look at it from an academic perspective, there are doctors who feel like being active means let's try and do something while things happen. Let's try and get ready for new trials, for new opportunities, for lab activities that, for example, in Southampton we are doing. So all the clinicians are divided into doing clinical and academic work. Now, the way I want to introduce myself is, as you know, I am Italian, imported in the UK, and I was quite attracted by entering the castle yesterday. There were these first high and mighty. So it says tribal leaders exchange gifts with the Romans. Then the poster next to it, last orders. Legendary warriors leave the hill fort to die in battle in England. So what has happened yesterday for me was, oops, am I using it or is it working or? What has happened yesterday, I went to the castle and high and mighty, I met a very nice, and Scott, the week before I was with leukemia care at the parliament when it shut. And that's what you have there. So it really depends when we talk about real life, where we live and how we want to introduce ourselves. But let's look at it from this ambiguous situation where the ongoing complications of CLL are really, the questions are, before what the complications are, why there are complications. And there are CLL-related complications, and there are therapy-related complications. Then there is a setting in which the new therapies can create new information for which, as doctors, we are really not prepared. And I will give you some examples of what the experience from the doctor's perspective can be like in one single institute. So we look at CLL as a disease made of many genetic complications, but actually this is a disease where the evolution is depending on environmental interaction through a putative antigen, through a molecule that is called the B-cell receptor, which you have heard this BCR, B-cell receptor word, a lot now that the new molecules, the small molecules, have entered the clinical setting. And through this drive, chronic drive, there is a mechanism of sort of immune exhaustion that will eventually lead to evolution of the disease into a moment, progression of the disease into a situation in which therapy is needed or more therapies is needed. And then there is a complexity of factors that will define what will happen to that clone and what will happen to that patient. One of the most complex situations will be Richter transformation, but it will not necessarily be that only one. One common factor that is accompanying CLL is the immune suppression. So CLL is by definition a disease of immune suppressed patients. And the way immune suppression can be is in the next slide, is in different, can be through conventional laboratory parameters. We were saying, well, you all know about neutropenia, but there are many other defects that can be measured in numbers or in the lab in function that are not of common use, of common practice. But we know that there are defects of T-cell lymphocytes, there are defects of the normal B-cell lymphocytes, and there are defects that are related instead of to occupation of the bone marrow and the immunological environments of lymph nodes by the tumor mass. Next slide. So this is what happens, for example, to patients with CLL. Every dot is one patient. So if you see how the counts of the T cells, there is one marker that is called CD3, goes compared to normal individuals from CMBL through the most advanced stages, there is an increase, a paradoxical increase of T cells. So someone would assume that those T cells function. Well, probably they will work, but in which direction? So if we look at subsets of T cells, one is called CD4, another one is called CD8, cytotoxic or helper suppressor, depending on the subset. So they all increase, but with a massive increase of this part, CD4, and many of these CD4 are called regulatory T cells, immune regulatory T cells. So they turn the immune system down. And this is what happens, so in the advanced stages, that there is a balance towards the immune suppression of these cells. Now, the point is that we also see a defect of the B cells. What is the defect? So B cells produce antibodies. They are called immunoglobulin M, G, A, each with their function and with their role during an infective process. And again, if you look at each of them, you will see that there is a gradual decrease that is obviously associated with tumor burden, but not only, because if you go and see, next slide, if you go and see at a very early condition like small lymphocytic lymphoma, which is CLL just in the lymph nodes or predominantly in the lymph node, we see a reduction of the immunoglobulins already. So there is not massive bone marrow occupation there. But the immune system is suppressed. Next one. So in Southampton, what do? We obviously try and collect as many details that we can from the clinical side. So everything that we can get from each individual patient, thanks to what? To a big observational study. So this is an umbrella study in which we collate all the information with this big system edge that is actually used nationally as a trial implementing system. All clinical trials are, cancer trials are in EDGE in the UK. And through a massive effort, through the lab activity, we can look at function of those CLL cells or the environmental cells. We can look at the genetic characteristics. And this can all be done through a spread collaboration and interactions, funded interactions with collaborators throughout the world. Next one. Next one, I think we don't need to discuss that. So, for example, by looking at specific parameters, I'm giving you one of the most common molecular parameters. You've certainly heard about immunoglobulin genes, where there is those CLL with unmutated and mutated CLL. So if you go and look at patients who have not received treatment, so in early stage, you can obviously check all patients, but you check patients in early stage and you just monitor over time. You have this active observation phase. You will see that patients with unmutated immunoglobulin genes, the most aggressive, have also a characteristic to be bound to have their first serious infection, so something requiring at least systemic antibiotic, much earlier than patients with an indolent condition. This obviously tells you that the most likely possibility is that there is an increase of tumor mass, and with the increase of tumor mass, there is less space for the immune components. But it also tells you that the CLL cell is by itself active in suppressing the immune system. It's not a cell that sits there and does nothing. It's a cell that sits there and disturbs the others. Next one. So this is what happens from real life observation. This is one cohort. So if you go and see why our patients die, whatever the reason is linked or not linked to CLL, so obviously infection is a major component. Secondary cancers is another one. We are very worried about Richter's transformation, but it still remains a minor aspect. And then there is a bunch of other CLL-related causes. So these are the components. It's not CLL progression, the real factor. It's within the factors, but the mechanisms of the causes of death are here. This is what we need to tackle. Next one. On the other side, the dysreactivity of the immune system that CLL can cause is towards the other side. Instead of being not effective against antigens, against infective agents, it can be overreactive, and it can react also against parts of our body. So the most common complication, autoimmune complication, as you know, is autoimmune hemolytic anemia. But there is a bunch of other problems that I was looking at here. I don't want to go. We don't know whether there is an association, a simple association. These are patients with elderly patients with a series of comorbidides. But if you go and look at the numbers, really, the piece of cake with autoimmune conditions is not small. And why don't we discuss that much? Because we don't know what to do. And we just leave it put it under the carpet and try and do as little as possible. We have no tools to use. So we keep the biological information, but why is that? How is it going to operate between cells? Is it going to cause something subclinical? We speak between doctors and patients, and quite often, how are you? I'm perfectly all right. Then they start treatment, and for some reason, they tell you after 6 months that they feel much, much better than what they felt before treatment. But at that time, they felt like they were perfectly all right. Next slide. So we know the mechanism. These cells, just by being slightly triggered, they will produce immune suppressive molecules. One of these is called IL-10. It's called regulatory. It's called a regulatory cytokine. Regulatory means that turns things down in immunology. And there is a difference between the two subsets, where the unmutated and mutated subset, when they are slightly triggered by some elements in vitro, they will produce one less, one more IL-10. They will all produce IL-10. There is always something, we don't measure that in the lab, but there is always something happening while we observe the patients. Next. So this is a bit of how the theory behind this is. There is a component where the CLL cells might affect immunoglobulin production through effect of some ligands directly onto plasma cells, but there are also components where the CLL cell that gets into the lymph nodes gets activated, possibly to proliferate, but to do something else, and it will produce some regulatory molecules and turn down other arms of the immune system. We know about neutropenias, autoimmune neutropenias, but we don't know anything about other components of the immune system like macrophages. I throw names in as to say how complex the system is. Next one. So this is really what we could expect from and what we worry about as doctors while we turn the worries down to the patients. What we think in the back of our mind of what are the problems for a patient who is not receiving any form of therapy and I'm going to see every 6 months or every 3 months or every year. Those are the issues that we need to learn from. Then there is the setting in which patients will receive treatment. This part is hopefully going to go away soon, at least for the moment, until we know what to do for some lines of treatment. And I want to give you some example. Next one. An example of what the experience in real life is about patients receiving ibrutinib in any of these settings. So in Southampton, next one. So in Southampton, we have looked at 70 patients. I don't remember of how many. We certainly have more than 100 patients in follow-up, with a median follow-up of more than 4 years now. We have just looked at when these patients are going to stop ibrutinib for any reason. So as you see, all patients are projected to stop treatment at some stage. And what we learn from the literature is that they're projected to stop because probably they will progress, because they're progressing. If we go and see at the next slide, so the patients who are progressing are really a small minority within that. So it's at the time of interruption of treatment. And there are mechanisms by looking at the biology of the cell that we are investigating, in which we think we know the reason why some patients will progress and some patients will not. Some patients will not progress and some patients will progress. But beyond that, if we go further, next slide, the reason why patients stop ibrutinib is 50% of the patients toxicity, some form of toxicity. Then this number is big. I think these were patients who were not necessarily overtreated. This cohort is with patients who have received indeed from 0 to 6 lines of treatment, but the median number of treatments that these patients had received was 1 line. And often, since there is some consultant that is not very compliant with the UK rules, and I'm not going to say the name, they may have not even had rituximab. So to say, there is something happening during this active monitoring on treatment that we must investigate further. Then, while I was going to look at what toxicity meant to our patients, so a big bunch of patients, you don't have anything of this in the leaflets. A big bunch of patients clearly were very old, but what happened to me, I saw a big number of patients who had to stop treatment because they forgot. They had real development of dementia. So a real cognitive state deterioration. I don't know if it is anybody else's experience. So clearly in the small numbers, we can't say much. But if we try to pull this information, this 43% is a massive group of patients. Atrial fibrillation, 24%, is a minority. We all talk about atrial fibrillation. It's easy to objectively measure that. But this aspect, to me, is scary. We have other problems that are not the diarrhea, the ingrown nails. 1 out of 5 patients eventually will stop because they have an ingrown nail. You do not want to think about stopping a treatment because you have a bleach in your toe. So the reality is this one, and there is no biology that is covering these aspects other than going to investigate why we're using this drug, why do we need to use another drug, which is through a mental path, our specialist path, that must not be commercially oriented, as we unfortunately all are to sustain the NHS system. So the next one. So if we can go back, since this is the last slide, if you can go back, the other point is the important bit that I wanted to show. CLL progression in itself at time of suspension is really a minor problem. So we are in the setting, if you can conclude, we are in the setting where novel therapies can be informative on what they really do, not only to the clone, but outside the clone, most likely by real-life observation into patients. I wanted that to be probably a bit more provocative as a slide, but I wonder whether this advocacy group really can help move our directions towards what is doctors' experience. Is it that we have to say what the books say, or is it that we have to say what we have in our cohorts? And I think I can stop here.